I completely agree with the functional dyspepsia. I've become more comfortable as we treat IBS, right, with treating functional dyspepsia with neuromodulators, especially the epigastric pain syndrome. But as you clarified that, that's really 16%, but then there's of course an overlap with the postprandial distress syndrome. But I think that's where we need to tease out which types of patients really are neuromodulators effective in. I think the Asian consensus actually, they had neuromodulators as their guideline. They did agree on the use of that, and they actually did not agree on PPI therapy, which is interesting, right? So there is this transcontinental trend, and I think that's what's brilliant about Rome, is that we are bringing a global perspective to this, and we are, really trying to figure out which parts of the world are responding to which parts of medicine, which part of the treatments. And if we can standardize these questionnaires, standardize the way we do the testing, I think it will really highlight how we can treat the segments of population that may be from those places.
Mm-hmm. Brian, I also think you will agree that we have a lot of work to clarify ahead, and maybe this is one direction we could move in. But
yes, well, I was kind of smiling, Jan, as you finished up. I like the photograph of like 30 people who are really excited about this and working in your lab, which explains why Leuven is just so amazingly productive and contributing so much. I wanted to make two quick points. One is, Baha, once again, you kind of beat me to the punch, but I think it's important. We need to be good detectives, right? When somebody comes in with pain, nausea, and vomiting, we need to be great detectives. And Baha mentioned some of those things we need to tease out. Is it cannabinoid hyperemesis syndrome? Is it cyclic vomiting syndrome? Is it median arcuate ligament syndrome? If you believe in that, is it SMA syndrome? Maybe primary or secondary because they've lost a lot of weight. But more important too, and rumination syndrome, of course, but more important too, I think our listeners, and I think all of us on the call tonight, have become comfortable with the concept of constipation, meaning, is it chronic idiopathic constipation or IBS with constipation? Does it really matter? Treat the predominant symptom. And so when we're facing these patients now, that last slide was such a nice illustration, meaning if it's nausea and vomiting, treat that predominant symptom. If it's pain, predominant. If it's epigastric fullness, treat the predominant symptom. And I think we're getting better dealing with that. And we don't necessarily always need to put a perfect label on it.